Let's join Dr. David Weissmiller for a discussion on abnormal uterine bleeding.
We're going to turn our attention to abnormal uterine bleeding. So if we move into that segment and find your audience engagement system, I have nothing to disclose still. This is our learning objectives, and we'll start with this question. The onset of heavy menses at menarche is often the first sign of what disorder of hemostasis? Hemophilia A, von Willebrand's, Christmas disease, or immune thrombocytopenia? Excellent. B is the correct answer, which is von Willebrand disease. So let's start by looking at the definition, and it's pretty broad. I've got menstrual flow, and it's outside what I would consider normal volume, duration, regularity, or frequency. Any of those can be altered, and we will have some disorder. Now, here is the most recent nomenclature put forward in 2011 and used in ICD-10. This nomenclature has been used to standardize the terminology. So we have abnormal uterine bleeding, which is then paired with a descriptive term, either heavy menstrual bleeding, so we've gotten rid of menorrhagia, or intermenstrual bleeding, getting rid of metrorrhagia, and then it's paired with an etiology or etiologies using the Palm-Coin classification system. So you can see there I've done heavy menstrual or intermenstrual bleeding, and then I'm going to evaluate the patient based on history, physical, laboratory, imaging, potentially biopsy, to determine whether it's a structural cause or a non-structural cause. Important is they recommended the discontinuation of this rather nebulous term, which is called dysfunctional uterine bleeding. Now, why do we have abnormal uterine bleeding if we look at the pathophysiologic state here? Well, we've just said we could have a structural issue, we could have a systemic issue. Those can be inherited or acquired. Then we have to move into either ovulatory issues, where there's normal ovulation, or ovulatory dysfunction. Now, with the ovulatory AUB, essentially your hypothalamic, pituitary, and ovarian axis is intact. If you look at steroid hormone profiles serologically, they will be normal. Where you will find an issue, particularly once menses has been established, is that I've got an abnormal prostaglandin synthesis or some receptor issue, I have increased local fibrinolytic activity, or I have increased TPA activity. Ovulatory AUB actually accounts for most causes or most cases once you've established regular menses. Ovulatory dysfunction can occur, and of course this is where you get a spectrum of disorders. The most common one is the result of an endocrinopathy, which is PCOS. Here, the basis is I've got unopposed estrogen. Too much fertilizer on the lawn of the uterus, and the lawn just keeps growing and growing and growing. So you can think of your uterine lining as a lawn. Okay. Now, what about the diagnosis? Well, we've got to get the medical history, and important in this is a family history of abnormal uterine bleeding or other bleeding problems. Because look at this statistic. Up to 20% of women, regardless of their age, if they present with heavy bleeding, will have some underlying bleeding disorder. That's a disorder of hemostasis. Adolescents, it is not uncommon to find von Willebrand's disease. Adult patients with a positive screen may be needed. Now, how would you determine a positive screen? I have a structured medical history. Here is how I would identify those patients who may need to be screened for some type of underlying disorder. They have heavy menstrual bleeding since menarche. I've never known anything else. Or you find that she's had a postpartum hemorrhage or surgery-related bleeding or bleeding associated with dental work, or two or more of the following: easy bruising, epistaxis, frequent gum bleeding, or family history. If they on medical history screen positive, the valuation then becomes a CBC with platelets and a PT-PTT. You can do a fibrinogen and a thrombin time. You do not need a bleeding time. And then you need to look particularly for a von Willebrand factor. These patients may benefit from consultation with a hematologist. Now, in addition to the history looking at the family, the other important medical history, because people take other people's medications. People take all kinds of things. Interesting fact, For every 10 people in this country who die from a medication-related issue, it's because 7 of 10 were taking somebody else's medications. That's pretty impressive. And you hear it all the time. I hear it all the time, you know. Well, what did you take for it? Well, I don't know. The naproxen didn't work, so my friend gave me something that began with a P. Was it a Percocet? Oh, yeah, I took 2 of those. How did it work? Oh, great, I felt wonderful. What about other medications or herbs or remedies? One important one up there is many women do not consider hormonal contraception as a medication. Are you on any meds? No. Oh, it says here you're on a combined oral contraceptive. Oh, I do take a birth control pill, you know. So very important to specifically look at some of these issues. Now, we've done our history looking particularly at pharmacologic and medical history and family history. What about the physical findings? Well, we need to look at weight. We need to look at signs of PCOS, particularly hirsutism and acne. We need to look for signs of thyroid disease, and then we need to look for signs of insulin resistance. I had an 18-year-old come into the office last week. She said, and I said, why is she here? To the nurse, she said she's got a rash on her neck. The rash was acanthosis. 18 with a BMI of 60. This is not her. This was another patient of mine, but you can see this in the flexural and creases. You can find this hyperpigmentation. Lastly, always look at the vagina and the cervix. On the exam, make sure if the option is to take a look. You don't want to miss the stage 2B cervical cancer. You know, bleeding, I can't do a PAP today. So we've looked at the medical history. We've looked at the physical examination. What about a laboratory test? Always rule out pregnancy. I'm not sexually active. Well, your pregnancy test is positive. Well, how did that happen? And you're 25 weeks along. Well, I can't be, because my boyfriend's here and I've only known him for 12. CBC looking for anemia and thrombocytopenic bleeding. We've talked about the screening for bleeding disorders. All adolescents with heavy menstrual bleeding, and then the adult patients who screen positive get a TSH, get a chlamydia, the most common reported sexually transmitted infection. The most common sexually transmitted infection is HPV. The most common reported is chlamydia, and then a PAP if needed. We'll talk about those recommendations another day. Okay, we looked at laboratory. Now what about imaging? Who might need imaging? Well, if you look at the literature on this, unclear, so I'm providing some suggestions. You do a physical examination and it's abnormal. You know they've got an enlarged or globular uterus. You think they've got a polyp. You've treated them, the pelvic exam is normal, but they're still having the bleeding going on. Keep in mind that when we're looking at measuring endometrial thickness, do not get confused. The transvaginal ultrasound looking at endometrial thickness is a means by which you can evaluate postmenopausal bleeding. But if you're premenopausal, you should have a thick endometrium, right? You're under estrogen stimulation, okay? So that's not necessarily as helpful here. Here is some guidance as to who might need diagnostic evaluation and how. Transvaginal ultrasound is currently, in terms of the exam, the correct answer. Helpful for evaluating the myometrium itself. Where really it is moving is saline infusion sonohysterography, because you're able to expand the uterus and get a better picture of what it looks like as opposed to this rather inert, collapsed organ. Superior, particularly if you're looking for polyps and submucosal leiomyomas. In addition, if we're going to need to biopsy, it may be able to help us look, is it a focal thickening or is it a uniform thickening? If it's uniform, I'll go with my endometrial biopsy using an endometrial aspirate. If it's focal, I may want to encourage someone to undergo a hysteroscopic evaluation so I can specifically biopsy that particular area. Diagnostic hysteroscopy, numerous of studies have shown it to be better in terms of diagnostic performance as compared to saline hysterography and transvaginal ultrasound, much more precise. MRI only helpful if you need to look at treatment of myomas, but in general, not necessary. Now, the next issue, we've looked at our medical history, we looked at our physical, we looked at laboratory, we looked at potential for imaging. What about a biopsy? Well, here I'm looking for atypical hyperplasia. Hyperplasia in and of itself, although not normal, does not in and of itself have an increased risk for carcinoma. What we're looking for is atypical hyperplasia, which does. And I would say that the new 35 is age 45. And really, if you're over 45 and you're presenting with what you are considering abnormal uterine bleeding, that patient is going to need an endometrial biopsy in general. If they're younger than 45, but they're obese, have PCOS, failed medical management, persisting AUB, they may benefit as well. This requires a conversation with the patient and a lot of the patient characteristics, but we're going to just make this as a broad statement in general, particularly for the examination. Now, in considering the results of the biopsy, which of the following statements is true? Secretory endometrium is normal in the follicular phase. Proliferative endometrium is normal in menopause. Atrophic endometrium is seen in women on Depo-Provera. Hyperplasia is the advanced effect of unopposed progestin. And you like C, which is atrophic endometrium, is seen in women on Depo-Provera, or any progesterone-only contraceptive, we might say. That is the correct answer. Now, let's take a look at what our results will be. Proliferative will be normal in the follicular phase. If you've got abnormal bleeding and you're in the proliferative phase, you've basically confirmed anovulation and you've got unopposed estrogen. If you have secretory or menstrual, we know that ovulation has occurred. If you have hyperplasia, this may be the advanced effect of unopposed estrogen. The atypia is what one would consider premalignant. And then it's atrophic, menopause, may see this with OCPs, Depo-Provera, and potentially if somebody is on continuous hormone therapy. Now, if we've done that evaluation, what am I considering then in terms of the differential? And I've broken this down based on age. Those who are younger, I'm thinking persistent anovulation, immaturity of the HPO axis, hormonal contraceptive, pregnant, infection, coagulopathy, possible a tumor. If I move 19 to 39, definitely I'm thinking pregnancy. Is there a structural lesion? Do they have an endocrinopathy such as PCOS? Are they on a hormonal contraceptive? Do they have endometrial hyperplasia? And then lastly, in those 40 years to menopause, I'm moving towards anovulation, but now I have to start thinking about hyperplasia, carcinoma, atrophy, and leiomyomas. At what point in the evaluation will I start my therapy? I'm going to go back to, if they're low risk, you can do an empiric trial of what we're about to talk about. If they're higher risk, particularly 45, prolonged anovulatory cycles, or persistent bleeding despite therapy, they're going to need a complete evaluation before you start any type of empiric therapy. Now, these are generalizations. More important for the exam, you're going to have to weigh in some of the risk stratification one might do in addition to family genetic history before you make these types of decisions with the patient. Now, how are we going to treat it? Well, we either have thick endometrium or thin endometrium. If it's thick, I got to get rid of some of the thickness, and I can do that using progestins or OCPs. Who's going to have the thick? I'm obese, I'm not ovulating, I have PCOS, or I'm taking unopposed estrogen. That would be uncommon, but you never know. Now, some of these patients may require emergency management because the endometrium has grown so much, it's outstripped its blood supply. All of a sudden, you've got a denuded endothelium or endometrium, and you're bleeding like crazy. We give IV conjugated estrogen until the bleeding slows. Now, you're thinking, now, wait a second. The patient has had too much estrogen on board, and I'm going to give more? Yes, because it does things actually at the capillary level to stimulate clotting. You get a rapid growth of the endometrium. This is going to cover that bare, denuded area. 75% of these women will be controlled in 6 hours. Now, luckily, We don't in practice need to reach for IV very often, and we can use oral conjugated estrogens. 10 milligrams, 4 divided doses, you can substitute that for the IV estrogen. Once the bleeding has slowed, you can start OCPs, or you could put them on a monthly progestin cycle. Most people wouldn't want to do that. However, OCPs are probably the best thing to prevent the recurrence. Non-emergently, 1 combined hormonal OCP for 7 days, stop them after 7 days, begin a combined OCP for the next 3 to 6 months, or you can do cyclic administration of progesterone similarly. Now, what about if it's too thin? It probably was too thick at some point, and they had this heavy continuous bleeding. Estrogen followed by progestin. Now, why would it be too thin? What might be some of the attributes they would give you on the examination that says, she's bleeding and it's too thin? Well, I've been on a high progestational OCP. I've been on a progestin-only contraceptive. The treatment is to add estrogen. Or if I've been on a mini pill, to a standard dose combination OCP, or change OCP to something that is not as progestational. Keep in mind for the exam, if they give you an example and they say you put them on progestins and it got worse, then you know the endometrium was too thin. It's going to make a bad situation even worse. Who has thin? Well, I've been bleeding a lot, progestin-dominant pill. There are a few people who will have low body fat. Eating disorders are some of the elite athletes, particularly if we're looking at figure skating and gymnastics. Treatment, a host of medical issues that can be brought to the attention. NSAIDs, they decrease prostacycline, they can decrease the blood flow up to 50%. The one that has been studied and reported most is Ponstel or mefenamic acid, but any of them can be used. Danazol, it's an anti-estrogen. The side effects usually will limit its use. Most people will reach for an OCP. A levonorgestrel intrauterine system. I've got abnormal uterine bleeding, too thick, and I also want a form of contraception, then a levonorgestrel intrauterine system may be appropriate. Some people will require surgical intervention, and that really has moved towards ablation and some of the more prominent second-generation methods. Keep in mind, though, with ablation methods, you do need to rule out pre-invasive and invasive endometrial lesions before the procedure, and you have to have completed your childbearing. In terms of treatment of AUB, here's the Cochrane review from 2005. This is a very interesting review from the standpoint. Ablation is more effective with fewer side effects than any of the medical therapies. Interestingly enough, women who were facing a hysterectomy, who got a levonorgestrel intrauterine system, up to 65% of them canceled the hysterectomy with hormonal manipulation. However, hysterectomy does have very high satisfaction rates. You've got to deal with the major complications of significant surgery. Okay, so here is a schematic which I've put together that reviews what we just stated. What I want to say here is, if I have enhanced risk of hyperplasia or neoplasia, there on my left, office endometrial biopsy. If I'm looking at an enhanced risk of a structural abnormality, I'm looking at a transvaginal ultrasound, although we are moving more towards saline infusion hysterography. The transvaginal ultrasound is the correct answer for the exam now. And we've just reviewed that particular piece, a Source C recommendation. 26-year-old female reports the absence of menses. Oh, put that schematic in your study folder. In your study folder, that's for you. She reports the absence of menses for the past 5 to 6 months. She is currently taking only a multivitamin with 400 micrograms of folic acid. You confirm that she is not pregnant and order additional laboratory evaluation. The TSH, the LH, and the FSH return normal, but she has an elevated prolactin level. Which one of the following would be most appropriate at this point to further evaluate her pituitary gland? Repeat the serum prolactin level in 4 weeks. Prolactin-stimulating hormone level, an MRI of the pituitary, or a head CT with intravenous contrast. Okay, the majority of you chose answer C, and that is correct. We will choose an MRI of the pituitary. This moves us into a conversation looking at amenorrhea. Some of the signs and symptoms we want to focus on are thyroid disease, estrogen deficiency, androgen excess, particularly PCOS, or a pituitary tumor, such as a prolactinoma. Those are the four I would keep in mind. In evaluating amenorrhea, I can't be pregnant. You are. Rule out pregnancy, a TSH and a prolactin, and then the next thing we're going to need to do is determine the relative estrogen status. How do we do this? 5 to 10 milligrams of medroxyprogesterone acetate. We give it for 10 days daily. We withdraw it. Any bleeding, even a drop, is considered positive if it occurs within 2 to 7 days. So if we think about amenorrhea then, I've done my TSH and my prolactin. If those are elevated, I'm going to have either a hypothyroidism or pituitary disease, and therefore an MRI to evaluate the pituitary. Let's say the TSH and prolactin, though, are normal, and I have a withdrawal bleed. Then I'm dealing with anovulation. TSH and prolactin are normal, and I withdraw. I'm dealing with anovulation. Anovulatory amenorrhea, frequently in obese women, PCOS, what you have is inadequate progesterone during the luteal phase, and therefore the endometrium is under estrogen stimulation. These women may have an increased risk of endometrial cancer because of ongoing stimulation. We treat this typically by resetting things with an OCP. Now, what about if the TSH is normal and the prolactin's normal, and you do the estrogen or the progestin challenge, and they don't bleed? Now I got to stimulate them with both estrogen and progesterone. I can do this by just administering an OCP. I take it away. If they don't bleed with that, they have an outlet flow tract obstruction. And then lastly, what about if they do bleed with that? So they didn't bleed with the progestin challenge. TSH and FSH are normal, or TSH and prolactin are normal, and they have a withdrawal bleed with estrogen and progesterone. Now I need to measure an FSH and an LH. If that is high, I have ovarian failure. If those are low or normal and I have a normal MRI, I have hypothalamic amenorrhea. So those are the 5 possibilities. Now, with hypothalamic amenorrhea, low or normal FSH and LH, they will have a withdrawal bleed. I've excluded a pituitary lesion. Typically, these are women with anorexia, stress, lots of exercise, can be chronic illness. But keep in mind, if you're presenting with a chronic illness with a systemic manifestation of amenorrhea, you're going to have other signs and symptoms of that disease before you become amenorrheic. Now, why do we worry about amenorrhea or hypothalamic amenorrhea? Inadequate estrogen. They're at risk for decreased bone density. We don't know if there's a change in the rate of fractures. We do know that putting them on OCPs improves lumbar and total bone mineral. We want to restore the BMI greater than 20. Wouldn't we all love that challenge? We just got to get our BMI above 20. Decrease the intensive exercising. High FSH or LH, I've got ovarian failure, maybe postmenopausal. If they have the absence of secondary sex characteristics, with a high FSH and LH, you're dealing with gonadal dysgenesis, and the most common form is Turner. 22-year-old female presents with the complaints of irregular menses, increased facial hair, and acne. Your evaluation leads to the diagnosis of PCOS. Which one of the following is the first-line treatment for her constellation of symptoms? Clomiphene, metformin, hormonal contraceptives, or spironolactone? Okay, so we have a learning opportunity here because the correct answer is C, hormonal contraceptives. We'll take a look at this when we get to treatment, but first let's look at the consensus definition of PCOS. Typically no ovulation and infertility. I either have cutaneous stigmata or biochemical evidence of hyperandrogenemia, and on ultrasound, the presence of one polycystic ovary. Typically, these are younger women. It's puberty to the mid-20s. We need their blood pressure, their BMI, their waist circumference, and then looking for those stigmata of hyperandrogenism, which can include acanthosis because of the insulin resistance. Here's the suggested evaluation from a laboratory. You can do total testosterone and sex hormone binding globulin. You want to evaluate for metabolic abnormalities, lipid and lipoprotein level, and then we've got to exclude other causes of hyperandrogenism. That includes a TSH for thyroid disease, prolactin, 17-hydroxyprogesterone, again looking for adrenal hyperplasia. This would be the form due to 21-hydroxylase deficiency. You would want to consider screening for Cushing's and then do a transvaginal pelvic ultrasound to evaluate for cysts on the ovaries. Now, these cysts on the ovaries are interesting. Let's take a look at that for just a moment to secure that in our minds. Now, the hyperinsulinemia with PCOS is that we see insulin sensitivity decreasing with the release and circulating insulin, therefore, increasing, because the body's saying, I need more, I need more. So half of women who have PCOS will have impaired glucose tolerance. This insulin resistance actually stimulates the ovarian androgen production. Therefore, we get anovulation. With the anovulation, the ovary's like, I don't know what's going on. I'm just going to try to keep producing ova. These multiple cysts develop because you can never get them out of the ovary. The hyperinsulinemia, the hyperandrogenemia interfere with the secretions of the gonadotropins from the pituitary. That's interfered with, so I never get the normal mid-cycle LH surge, and therefore I can never kick the developing follicle out. So that's the whole relationship between the insulin resistance and development of these polycystic ovaries. Management, if they have oligomenorrhea and amenorrhea, OCPs or monthly progesterone. Hirsutism, OCP, spironolactone. So that's what our patient was dealing with, the amenorrhea and the hirsutism, so we chose OCPs. If she has infertility, metformin, clomiphene can be added, and then if there's insulin resistance, metformin. Key points: improve the insulin sensitivity. Metformin or clomiphene alone or in combination are the first-line treatment for ovulation induction. Perimenopausal bleeding. If you can't rule out pathology, you're going to need to do an endometrial biopsy first. OCPs can be helpful in treatment. Levonorgestrel can be helpful in treatment. Here, if you're going to put them on hormone therapy, sequential is more effective than continuous. It prevents the hyperplasia, but you do not get the contraception. What would we be looking for on biopsy in these women? Atypical hyperplasia. Endometrial hyperplasia is the benign condition. It is the atypia that we need to worry about. Our last question. A 55-year-old postmenopausal woman presents with 2 days of vaginal bleeding or spotting. She initiated hormone therapy 10 months ago because of significant nocturnal hot flashes. Which of the following statements is most accurate? Irregular bleeding is uncommon after HRT is initiated. Postmenopausal women on hormone therapy for more than 4 months who experience bleeding require prompt evaluation. Postmenopausal women on HRT for less than 12 months who experience bleeding may be observed for 1 year before diagnosing abnormal uterine bleeding. The sensitivity of endometrial biopsy for the detection of endometrial abnormalities is 50%. Okay, so the correct answer here is actually C. Postmenopausal women on HRT for less than 12 months who experience bleeding may be observed for 1 year before diagnosing abnormal uterine bleeding. Here is the bottom line. Once you start individuals on hormone therapy, it is not uncommon to get irregular bleeding. Here are the 4 groups that probably need evaluating. If they're on cyclic HRT and they have prolonged or heavy bleeding that occurs near particularly the end of the progestogen phase of the cycle, or if they have breakthrough at any time during that cycle, they should be evaluated. If they're on continuous and experienced bleeding that persists greater than 6 to 12 months, or I've established amenorrhea and bleeding develops. If I'm on HRT for less than 12 months, they can be observed for up to 1 year before diagnosing abnormal uterine bleeding. or if I'm postmenopausal on no HRT, or I've been on it for longer than 12 months and develop bleeding. So those are the 4 groups with which you would be dealing and deciding, do I need to do an endometrial biopsy or transvaginal ultrasound to evaluate? And we'll discuss that a bit more in a future lecture before you guys leave. Okay, here are our practice recommendations that we have highlighted. Please print these out and put them in your study folder. I've pulled out those SOAR criteria. I've also created a summary slide here which looks at medications that can be used. That should be put in your study folder. And then our SORT key recommendations for practice, please put that in your study folder as well. And with that, thank you very much for your attention. I appreciate it.